I think there are several major challenges in treating patients with MDS and MPNs. There's a significant lot of biologic overlap and clinical overlap. Anemia remains a challenge for many patients. It's a poor prognostic marker in both diseases. In low-risk patients, often the therapeutic target is trying to alleviate anemia and transfusion dependence in myelodysplastic syndrome patients. And increasingly, as patients advance with myelofibrosis, for example, anemia becomes an issue. So therapies that can alleviate that are desperately needed for both MDS and MPN patients. Therapies that go beyond ESAs and immunomodulatory drugs, so drugs like luspatercept, which is an activin ligand trap, or even imetelstat in MDS patients, or luspatercept in myelofibrosis patients, or even combination therapies with JAK inhibitors like CPI 0610 are all examples of therapies that have the potential to alleviate anemia and reduce transfusion burdens. I think a lot of the advances are in prognostication and refining prognostication by incorporating molecular markers both in MDS and MPN to better tailor risk-adapted treatment approaches. The mainstay of treatment for lower-risk patients with anemia still remains ESAs and immunomodulatory drugs. But I think drugs like luspatercept, which is an EMA and erythropoiesis maturation agent, can offer an alternative for patients who failed ESAs or were not eligible, who do not have 5q minus syndrome, for example. Therapies like imetelstat, which is a telomerase inhibitor, which has also been evaluated in lower risk patients without 5q minus, may be an option both to address anemia, but also potentially to have a disease course modifying aspect. And really in high risk patients who fail hypomethylating agents, which is the first line of therapy, salvage regimens or therapies that could improve outcomes, because that's a dismal prognosis. Similarly, in patients with myelofibrosis who fail first-line JAK inhibition, the outcome is pretty poor. So we're in desperate need of therapies that can improve the outcomes in those patients. So whether it's a novel JAK inhibitor or a total novel pathway inhibitor, BET inhibitor, or BCL2, BCLX inhibitor that could improve HMA failure or JAK inhibition failure. The factors that are important, I think, both in MDS and MPN are the age, the comorbidities and performance status of the patient, and then importantly, which is sometimes I think forgotten or not addressed, is the patient's expectations and goals of therapy. Sometimes we as physicians impose what we expect or we want for the patient without considering that it may not be in line with their treatment goals. So one has to really individualize the care of the patient and consider all those factors. So I think patients who progress, for example, MDS patients who lose response or have progressive disease on a hypomethylating agent really should be considered for clinical trial enrollment whenever possible. Those are patients who, if they have a transplant option, really should move to transplant as quickly as possible. But that marks an unmet need, an urgent unmet need with a very bad outcome in a very complex disease. And again, similarly, in patients who are receiving JAK inhibition, who fail, who have progressive disease or evolution of their disease, do very poorly. So salvage therapies and the ability to get some of those patients to transplant, which is the only curative option, has really been the focus of a lot of clinical trial efforts. I think we're going to see more and more molecularly targeted therapies. So as we understand the molecular mechanisms that underlie these myeloid malignancies, so to give you an example, in patients who have IDH2 mutated myelofibrosis or patients who've progressed to MPN blast phase, combination JAK2 IDH2 inhibitor is a trial that we have through the MPNRC consortium. So I think there's insights that we're gaining today from the laboratory investigation that will inform hopefully targeted or informed mechanism-based treatments tomorrow.